ضياء احنا جاهزين سيدي، تفضل. اهلا وسهلا.
السلام عليكم.
بنرحب دكتور ضياء
evening.
رشدان سيدي. الله يعطيك العافيه دكتور ضياء، شكرا لجهودك
الله يعافيك.
المتواصله. طبعا دكتور ضياء رشدان اخصائي عظام اطفال. اليوم طبعا زي ما بتعرفوا مركز فرح شباب ممتنين مركز فرح كان معكم دكتور ضياء الصبح لكيس ديسكشن بعنوان فيزيال انجريز. الان راح نحكي عن الموضوع بشكل اعم بشكل تفاصيل اكثر. حضرها دكتور ضياء بشكل مرتب ان شاء الله. الان راح نكون معه خلال هاي الساعه. دكتور ضياء تفضل سيدي.
السلام عليكم، يعطيكم العافية جميعا. Good evening everybody. Today I will talk about an important topics in trauma, which is the physeal injury, especially in the pediatric. We will start with the objective of this lecture. The first is to learn about the physeal fracture, epidemiology and etiology, and the classification of the physeal injury, which is the most common classification, and which is the Salter-Harris classification. And we will study about the growth plate anatomy, Salter-Harris type and treatment, and principles of the treatment, growth plate disturbance, complication of physeal injury, by mechanism of Pony bridge and its classification, and post-fracture growth arrest, what to do, and example of cases. We will start with the anatomy of the physes. As we know, the physes, it is present in the long bone, which is responsible for the longitudinal growth of the long bone. We know that is surrounded by the epiphysis and the metaphysis. Before we start, we will know the zone of the physes, which is combined of germinal zone, proliferative zone, hypertrophic zone, and zone of enchondral ossification. As we know, the longitudinal growth of the bone in the long bone start from the epiphysis side to the metaphysis side. So here will be the epiphysis. اوكي دكتور ناصر اظن المؤشر البوينتر واضح مظبوط؟
واضح سيدي موجود.
اوكي. So here is the epiphysis part and here is the metaphysis part of the long bone. There is a three main blood supply for this region, which is by epiphyseal artery, which is supply the epiphysis, and the metaphyseal artery, and the main blood supply of the physes, which is the perichondrial artery. We know the types of the bone formation in the physes is the enchondral ossification. It is start from in the germinal zone, in the resting zone of the germinal, start by inactive chondroplast. Then it is will proliferative to be inactive. It is aggregate as a columns, so it is called proliferative zone. Then it is called the hypertrophic zone. What happens in the hypertrophic zone? In the hypertrophic zone, the active chondroplast will be end by dead cells. Through the growth of the chondroplast, it is secreted an extracellular matrix. So after it's dead of the chondroplast, the osteoblast comes from the side of the osteoblast, from this blood vessels, okay, and it is sedimentate of the calcium and phosphorus, which is called the ossification. So here in the hypertrophic zone, it is a conjunction between two parts, mineralized of the metaphysis and the epiphysis, okay? So it is the weakest part of the physes. So it is the most common site for, to present of the physeal injury, of the fracture. Okay. Then we will consider about the zone of Ranvier and ring of Lacroix. Zone of Ranvier, it is responsible for oppositional growth. It is responsible for the wideness of the physes. And ring of Lacroix, it is responsible to give a more stability to the physis, to the surrounding periosteum. Regarding the epidemiology, we know that the overall frequency of the fracture, percent of the children sustaining at least one fracture from 0 to 16 years of age, for the boys, it is around 42 to 60%. For the girls, it is 27 to 40%. You can imagine that 15 to 30% of all these fracture, it is considered a physeal fracture. Okay, and the injury usually present in the hypertrophic zone in the provisional classification, as we mentioned before. It is the weakest part. Why? Because it is weakest 2 to 5 times weaker than the surrounding fibrous tissue, so the growth plate fail before the ligament. And the physeal cartilage is also more prone to tension and shear forces than adjacent bone. This is the causes why the physeal fracture occurs in this zone, in the hypertrophic zone. We can classify the causes of physeal injury to 3: accidental trauma, like sport-related activities, motor vehicle accident, or non-accidental trauma, child abuse. Keep in mind that usually in the ER, we face many children came with trauma, physeal injury. We will consider the child abuse, especially in the younger children, multiple level grade of healing of the bone, trauma to the back and the chest. Okay, keep in mind this is a red flag to the child abuse. The third causes is pathological condition. All these conditions associated with physeal fracture. What's the importance of the physis? It is related to the growth. So we can imagine that in the upper limb, the major contribute of the growth in the humerus comes from the proximal humerus, which is considered about 80%, which is about 7 millimeter annually. While the distal humerus, it is about 20%, about 2 millimeter. This is why it has a low remodeling rate. This is why in supracondylar fracture, our aim is to restore the anatomical reduction to prevent a complication of malalignment. Okay. Also in the proximal forearm, in the radius about 25 and proximal ulna at 20, while in the distal forearm around the wrist, distal radius contribute about 75% and the ulna 80%. So there is a higher remodeling ability, and we can accepted angulation in this this region of the bone, especially if the angulation comes with the range of the motion. So in the wrist, if it's come with extension and flexion, we can accept it up to 30%. In the lower limb, which is the most important, the major growth comes from around the knee, from distal femur and the proximal tibia. It is about 1.5 centimeters. Okay, so this is area all make us to be highlighted to prevent injury and prevent complication in this area. Fortunately, the most common site of physeal injury occurs in the phalanges, while the area around the knee, especially the distal femur, contribute less than 2% of all physeal injury. We'll talk about the classification. There is a many classification for physeal injury, but the most common and famous classification it is which is called Salter-Harris fracture. It is a 2 Canadian orthopedic surgeon doing this classification in 1961. They classified the physeal injury into 5 groups. Okay, it started from A1 1, 2, 3, 4, 5, and we can mimic this classification as the word salter. So the type 1, which is S, it is separation through the physes, while type 2, it is above the physes. It is included the physes, and it is go through the metaphyses and make a fragment which is attached to the physes, which is called Thurston-Holland fragment. The type 3, it is lower to the physes. It is through the epiphyses, and it is considered intra-articular fracture like the type 4. Type 4 present with intra-articular fracture and with metaphyseal fracture. While type 5, which is very rare, but has a higher consideration related to the complication of physeal disturbance, it is just compression at the growth plate. We can see here, this is an X-ray for the ankle joint, okay, and show the 4 type of the Salter-Harris classification. Type 1, we can see just an widening in the physes. Type 2, we can see widening of the physes, and there is a metaphyseal fragment, okay. In type 3, there is an intra-articular and the widening of the physes, especially in the anterior lateral piece of the epiphysis, which is called Tellox fracture. Type 4, there is a vertical line comes from the metaphysis. There is a metaphyseal fragment through the physes, through the epiphysis. There is a modification in the Salter-Harris. They added in 1981 a 4 subgroup, which is called type 6, type 7, type 8, type 9. Type 6 comes with epiphyseal avulsion, in physis avulsion, through the attachment of the ligament. In type 7, there is epiphyseal fragment, okay. In type 8, there is a condensation in the metaphyseal and through the physis, and there is incomplete fracture in the metaphyseal area, while type 8, there is a periosteal sleeve in the diaphyseal region. As we mentioned before, the growth plate anatomy, germinal zone, proliferative zone, physis, hypertrophic zone, in chondral ossification. Where mostly occur the fracture through the hypertrophic zone. We can see here, this is the line of the fracture occurs in the hypertrophic zone. Why? Because it is present in between 2 regions, mineralized region and active region, the enchondral ossification here, and in the germinal zone and epiphysis. And this is make this area the weakest point of the physis. As details in the classification of the physeal injury, we'll talk about Salter-Harris type 1. Usually it is injured the physis only, most commonly involved in zone of hypertrophy. Usually a younger children comes with Salter-Harris type 1. How to manage the Salter-Harris type 1? If non-displaced and exam reveal tenderness, swelling at the physis, often with normal radiograph, treated with casting and immobilization. If displaced Salter-Harris type 1, we can fix it by percutaneous smooth K-wires, okay, through the physis. Usually why we use smooth K-wires, not threaded K-wires or the screw through the physis to minimize the physeal injury. In the study, how much the percent of the physeal injury that the physis can accommodate before a present of physeal disturbance, about 7%, okay? We can see here in MRI imaging in type 1 physeal fracture. This is an MRI for proximal humerus. There is a widening of the physis and abnormal signality. This is the wide, okay, which is this type represent of type 1 Salter-Harris, which is called in the proximal humerus little league shoulder, okay. This is an ankle MRI, show that the distal fibula, there is a widening in the physis, and there is periosteal signaling, meaning that there is a fracture here. This is a distal femur MRI showing a widening bright signal in the distal femur physis, which is means Salter-Harris type 1. In Salter-Harris type 2, usually it is involved the physis and above the physis through the metaphyseal area, where in the metaphyseal area, including the enchondral ossification. It is most common, considered most common type. It is about 85% of all physeal fracture. Okay, this is the Thurston-Holland fragment, which is it is a stable fragment. Okay, how to manage the type 2? We do close reduction and casting, and we can add percutaneous screw or wire fixation. If small fragment in the metaphyseal, just we fix it with smooth K-wires. If it is large fragment, we can fix it with a parallel cannulated screw through the metaphyseal area to the injured area. Here an MRI of the knee showing that there is a widening in the physis of the proximal tibia, and there is piece in the posterior segment of the metaphyseal, which is the Thurston-Holland, represents Salter-Harris type 2. Here an coronal view for the knee, showing that there is a vertical line through the metaphysis, and there is also a physeal plate widening, represents that there is compression forces, and also there is a periosteal involvement. Here we can see, comparing to the contralateral side, there is a periosteal sleeve and periosteal injury. This is the white, which is mean that there is hematoma. This represents an injured periosteum. In Salter-Harris type 3, usually the part that is involved, it's the physis and epiphysis. What's the zone that is involved? Usually the hypertrophic, proliferative, and germinal zone usually involved. Usually here, it is considered as intra-articular fracture. So we need an advanced imaging like CT scan to evaluate articular displacement. Treatment usually as intra-articular fracture, we need anatomical reduction, rigid fixation, absolute stability. Why absolute stability? To healing without callus. As we mentioned today at the morning, that we can accept up to 2 millimeter step off in the articular surface. Why? Because to prevent exposure of the subchondral bone. If it's the step of more than 2 millimeter, the subchondral bone, which is the beneath the articular hyaline cartilage, will be exposed to the joint. This make the healing will be secondary healing with the callus and end with arthrophyprosis and stiffness of the joint. Usually, the treatment will be immobilization and casting if non-displaced fracture, and we can exclude the step off, or if typically with the screw or K-wires if it's displaced fracture. Here, some imaging for the type 3 Salter-Harris. This is the distal tibia. We can see that this is an anterior lateral fragment of the distal tibia. This is a talus fracture. Also, this is a coronal view showing that this is a talus fracture. This is the line of fracture intra-articular. This is an MRI also. There is a widening of the physis, and there is a vertical line in the epiphysis. This MRI show early closure of the physis. In Salter-Harris type 4, usually all the fourth zone of the physis involved, which is the germinal layer, proliferative zone, hypertrophic, and enchondral ossification. Treatment usually close if non-displaced, usually ORIF with screw or K-wires if displaced. It is considered as type 3 intra-articular fracture. So we need anatomical reduction physis to minimize the risk of physeal part formation. Here is some CT scan imaging for ankle joint, showing this is the sagittal view, showing there is a vertical line through the metaphyseal area, which is represent the red line, okay? And the yellow line makes the horizontal fracture through the lateral growth plate, okay? And the sagittal line here, the blue line, represent the line through the epiphysis, which is called the triplane. Usually Salter-Harris type 4, usually called triplane fracture if it is in the distal tibia. Salter-Harris type 5, usually difficult to diagnose in the emergency room. So we need high suspicion for the diagnosis according to the history if there is high energy trauma. What can we do? Initial non-operative treatment, but we usually late diagnosis after complication, physeal arrest, and deformity has occurred. What's the principle of the treatment of physeal injury? Usually perform a careful reduction, usually 90% by traction, just less than 10% by manipulation. Why? Because we prefer to avoid twisting injury in the physis to prevent further injury of the physeal plate. How to limit a heterogenic injury to the physis? By decrease of repeated forcible reduction attempt more than 2. If there is late reduction, usually there is a late presentation of physeal injury after 7 to 10 days. So the advice not to do anything, just follow up, or hardware across physis. How to maintain the reduction? By cast, screw, and pins. Post-operative care, if pins cross the physis, typically remove at 4 to 6 weeks. Further immobilization based on the healing and signs of the healing. Growth plate check recommended after 6 months and 1 year after injury. Why after 6 months and 1 year? To exclude complication of the physeal injury of angular or longitudinal growth disturbance. Usually, if we have a suspicion for a growth arrest, we can obtain standing hip to ankle X-ray, which is called scanogram, okay, for the injured extremities to compare the two extremities if there is leg length discrepancy or if there is angular deformity. Regarding growth plate injury, what to look for? Usually, if we see that there is a loss of physeal contour, like in this image, we can see we can't show the physis. There is a condensation between the metaphysis and the epiphysis. There is no separation between the epiphysis and metaphyseal area. And if we can see pony connection between the epiphysis and metaphysis, or the tapering of Park-Harris growth line, we will mention after slide, toward area of a growth arrest. Usually obvious if there is obvious angular deformity of or segment shortening, if there is a central physeal par, result in cessation of longitudinal growth. Usually central physeal par affect the longitudinal growth, which make a limb length discrepancy, while the peripheral physeal par end with limb length discrepancy and angular deformity. Regard the Park-Harris growth lines. What is the Park-Harris growth line? It is a dense trabecular line of ossification within the metaphysis. We can see here, this is a lateral view of the distal femur. We can see this is the physis, okay? And this is the line, this is the Park-Harris growth line. Why it is present, this line? Because there is a transient slowing of the growth, or this make a more mineralization of this area, so it is appear on the imaging. Usually it progress away from and parallel to the physis with the normal growth. Usually it is a parallel and to the physis. If it is there is a signs of asymmetric and of Harris growth line, it is considered that there is disrupted growth. Regarding the physeal disturbance, usually there is a complete physeal arrest, usually in the Salter-Harris type 1 and 2. There is a longitudinal bony growth ceases completely at this physis. Symmetrical growth of Neporian bone, F2 bone present with the segment. You can see here, there is a growth arrest in the distal radius. What happens that the distal ulna, it will grow. This make this make a positive ulnar variance. There is impaction of the distal ulna to the carpal bone. If there is a partial physeal arrest, usually in the Salter-Harris type 3 or 4, there is end with angular deformity. We can see here, this is it is a type 3 Salter-Harris treated with a screw. It ends with angular deformity. We can see the heel goes with varus. Okay, regarding the physeal part, what the basic pathology for the physeal part? We can see here in the X-ray the physis. We can go with the physis, and this region that we can't see the physis. Just we can see that there is a bridging between the epiphysis and metaphysis. Why it is occur the physeal bridge? Because the tension forces from adjacent functioning physis, and there is a mineralized cortical bone forming between the metaphyseal and epiphysis. What's the importance of the Harris growth line? We can consider to the types of physeal part, either central or longitudinal or peripheral. Usually central, present with symmetrical Harris Park line. We can see on the right and the left, it is asymmetric, so it is called central. Usually this central has a good prognosis. It is affect just the longitudinal growth. And if we make a window in the metaphyseal area and reach this central physeal part, it is usually the effect is the central, while the peripheral physis, it is intact. It is called central volcano effect. It is like a volcano. So it is just the central part of the physis affect, while the surrounding physis, it is normal. In this X-ray, we can show that there is a valgus deformity of the knee. Normally, it is a valgus about 6 to 7 degrees. Here, it's about 22 degrees. We can see that there is a growth arrest in the lateral side of the distal femur and the proximal lateral side of the proximal tibia. So it is end with a peripheral Physeal part. This has a bad prognosis. There is another type which is called linear type. Usually the linear type, there is asymmetric in Harris-Park migration. It's different from central. What happens? It is a longitudinal Physeal part from anterior to posterior. Okay, we can see in this image, it is a longitudinal Physeal part from anterior to posterior, but there is a normal physis tissue surrounded. Usually it ends with growth disturbance, longitudinal growth, and in the angular deformity, usually associated with type 4, as we mentioned before. What are the X-ray criteria on the plain film? There is a Physeal narrowing absent Harris-Park migration. How to diagnose if there is a growth or Physeal part? Traditionally by fine cut CT. Now the MRI is the gold standard for diagnosis of Physeal part to assess the size, location, and if there is healthy physis tissue around it. What's the factor associated with higher rate of growth disturbance? It is related to the type of Salter-Harris fracture. Usually type 4 has highest rate over type 3, 2, or 1, while the type 5, it is, as we mentioned before, it is difficult to diagnose acutely in the ER, but has a late complication. So it is considered to have a higher rate of growth disturbance, type 5 and type 4. The anatomic location of growth plate fracture, it is related where the growth arrest occur, at what physis. Usually in the physis around the knee, distal femur or proximal tibia, have a much higher rate of growth disturbance comparing to the other region. So the rate of growth arrest by anatomic location, the distal femur and proximal tibia, this is a study showed that it is rate of growth arrest usually 50% to 40%. While the upper limb in the proximal humerus, it is rare to have a growth arrest because there is no weight bearing on that side. What other factor? The mechanism of the fracture, if it has higher energy, so it has a higher complication and high susceptible to have a Physeal injury. The amount of initial fracture displacement delayed, if it is more than 1 week history of the trauma. Amount of residual displacement after close reduction. Forceful or repeated close reduction. This is why we don't advise to make more than 2 attempts for reduction of the physis. What the modalities of the treatment if there is a Physeal disturbance? Either completion of epiphysiodesis. If it's the Physeal part more than 50% of the surface area of the physis, we advise to completion of epiphysiodesis. It is based on the growth remaining and must consider nephrotic bone. What's the meaning of this? As we mentioned before, the distal radius injury, there is a progressive growth of the ulna. So we advise to make nephrotic bone like ulna in the distal radius, epiphysiodesis to prevent a progressive growth. We can do Physeal part resection if there is size of the physeal part less than 50%, and the growth remaining more than 2 years or more than 2 centimeters. Other modalities, chondrodiastasis, it is mentioned in the literature, limb lengthening or deformity correction with circular fixation. Right now, we're doing with another modalities like rail system, or in the Western country, they do magnetic intramedullary device. How to know that there is a remaining growth potential for that the part of the bone? We can use this this program. It is called Multiplier. You can download it in the app, and here we can consider that the leg length discrepancy congenital or developmental, and we can calculate how remaining for the growth, what the advice to make epiphysedesis or shortening or lengthening. Okay. What are the prerequisites to consider a surgical par excision? As we mentioned before, more than 2 years of growth remaining or more than 2 centimeters. Size of the par should be less than 50% of the physis. Condition for successful par excision: smaller par, less than 30%, younger children, greater than 2 years of growth remaining. Central pars are more amenable than peripheral pars, as we mentioned before. The cause of growth arrest, the good outcomes come with traumatic rather than infection, metabolic bone disease, or ischemia. Here is the MRI and CT scan 6 months after 12-year female had close reduction and pinning of Salter type 2 distal femur. They make a closed reduction with pinning by crossing smooth K wires. After 6 months, they make a CT and MRI. What we can see in the CT and MRI, in the CT, we can see there is a central growth physeal part here. And on the MRI, we can delineate the physis, and this is a bridging between the epiphysis. This is the physeal part. What should be the treatment for this girls? The best is early, has a good prognosis. Treatment, either par excision if this less than 50% or more than 2 centimeters or more than 2 years. Either epiphysedesis, completion of the arrest if it's more than 50%, or contralateral epiphysedesis, limb lengthening or limb shortening. I put this X-ray to show that this is a new modalities of lengthening. It is intramedullary nail. It is a magnetic using for lengthening. We hope to have this device in the future. This is some example for physeal injury. This case one show there is a trauma for the distal femur, showing that this is a Salter type 2 because there is a metaphyseal fragment, Thurston Holland. What the management? Close reduction and percutaneous fixation. Here he make a crossing K wires. Case 2 present with Salter type 2, managed as intra-articular fracture. So we need anatomical reduction, rigid fixation, absolute stability, either with K wires or if can hold a screw. The screw is this. It's fixed with screw. After that, there's a growth arrest developed. This is the physeal part showing on the CT. They make excision of physeal part with interposition of fat. Usually we put a fat. 3 years, it is remodeling with the normal physis without complication. Case 3 is 10-year female after present after skiing, has distal femur comminuted fracture with intra-articular saltar Harris type 4. You can imagine on the CT, it is a complex fracture. First, there is fixation done through multiple screw. After that, they make a revision for the fixation. You can imagine how many metals they use it. Ultimately, there is a complete physeal injury. Anybody advised for physeal excision for this, such this fracture? Nobody, because there is a complete physeal injury. So what can we do? Here, after 1 year post-op, there is approximately 17 millimeter leg length discrepancy. Bone age is 11 years. Predicted to have a leg length discrepancy at the maturity about 4 to 7 centimeters. Usually, less than 3 centimeters, we can manage with shore rise or epiphysedesis. More than 3 centimeters, manage either with lengthening or shortening. So they make a lengthening for this patient. As a summary, physeal fracture, take-home message. Physeal fracture are common injuries, account about 15 to 30% of all pediatric trauma. Most heal and growth resume uneventfully. Principles of treatment must be adhered. Certain physes have propensity of a growth disturbance, like distal femur, proximal tibia, distal tibia. Treatment of a growth disturbance require consideration of patient age, current and predicted deformity, characteristic of the arrest, location, size, etiology. Thank you. Any question?
يعطيك العافية دكتور ضياء.
الله يعافيك. هلا
حمزة عطيل سيدي.
هلا حمزة.
يا سيدي سؤال سريع بالله بعد إذنك. في رول للستريس فيو تو دياجنوز ترانسفيزيال فراكتشر ولا حاليا كله على الام ار اي سيدي؟
هلا ستريس فيو احنا حكينا الكونسيدريشن اوف فايسز to prevent further injury to the physis. هلا اذا انت بدك تعمل انت ستريس فيو راح تعمل more damage. هلا عشان انت تكون بالصوره in the literature first attempt of close reduction make 11%، يعني 11% growth disturbance. two attempt بتزيد لحد 24%. فانت تخيل اذا انت بدك تعمل ستريس فيو للمريض already who have physeal injury وانت ما بتقدر تعرف قديش المقدار، انت راح تزيد الدمج للفايسز. فيعني I don't prefer to do stress view for such a physeal injury.
Thank you سيدي، شكرا.
Okay. Other question?
دكتور ضياء الله يعطيك العافية.
الله يعافيك. هلا سيدي.
هلا سيدي. Very well prepared. Thank you very much.
الله يعطيك العافية سيدي أبو ركان.
يا سيدي سؤال يعني regarding the literature that supports the modalities of treatment بالphyseal fractures والrest. يعني you mentioned بصراحة يعني treatment options بالمجمل يعني theoretically speaking أو hypothetically speaking كويسين جدا وراشنال، بس في مقارنات بين مثلا modalities of treatment بالمجمل عندكم بهاي الحيثية؟
يعني من اي ناحيه انت
يعني مثلا
physeal injury يعني مثلا تحكي lengthening shortening
100%. يعني
اوكي
يعني شو what guides your treatment؟ هل هو إشي يعني في evidence معين؟ عشان we weren't presented with evidence, we were presented by. الله يعطيك العافية. طبعا هي comprehensive المحاضرة، وديفنتلي بحاجة إلى جهد للتحضير، وبدنا نوصل معلومات محددة للشباب. But again إحنا التشويس تبعنا بالتريتمنت usually is based on evidence, especially comparative studies between different options of treatment. Is this valid for basically orthopedics, especially in physeal fractures؟ ولا هو عبارة عن إشي تعودنا عليه ومشينا عليه وأثبت عبر السنين إنه هو الحل؟ شكرا.
أشكرك يا سيدي بركان على السؤال. سؤال يعني يعني بصراحة comprehensive. هلا احنا بنحكي يعني المحاضرة كانت ايم للشباب المقيمين، احنا بنحكي عن acute management of physeal injury, how to diagnose, how to treat. هلا اذا بدنا نعالجها احنا acute تقريبا احنا حكينا التايب 1 وتايب 2 3 4 how to manage it either conservative or surgically. هلا بنحكي عن ال complication of physeal arrest which is most common in physeal part. If there is growth arrest either in longitudinal or angular, there is many modalities احنا يعني we mention it like lengthening, osteotomy, shortening contralateral side either by shortening acutely or by epiphysedesis complete. اوكي هلا اللي بداوا معنا احنا بالاطفال احنا يعني يعني we have many modalities of the treatment. بالعاده اللي بيتحكم بالقرار انه ايش اللي نستخدم مثلا lengthening ولا shortening في اكثر من معيار. يعني زي ما حكيت انا هنا في المحاضره الكونديشن اوف ذا بيشنت، الكونديشن اوف ذا بون. هلا مرات انت بدك تعمل مثلا lengthening بون هي all يعني already disease, we can do lengthening on that bone. تمام. هلا بالعاده مثلا زي المرضى هذول اللي بيكون congenital ما بنقدر احنا نعمل عليهم lengthening لانه already has a higher complication either for joint above and joint below like dislocation. We have faces some cases with complication of knee dislocation or hip dislocation. هلا بنروح على الشورتنينج. هلا what the patient decide كمان احنا دائما هاي الحالات احنا counseling with the patient. احنا كاطباء بنعرف الكونديشن اوف ذا بون، كونديشن اوف ذا بيشنت، الايج. حطيت انا المالتيبلاير اللي احنا بندخل بيانات المريض وبنحدد ايش الكوز اوف ذا ليب لينث ديسكربنسي، what the advice to make epiphysedesis or lengthening. هلا what the patient decide. هلا كل الخيارات هاي بنحطها قدام المريض، والمريض ايش هلا هو cooperative non cooperative. هلا بيختلف من مريض لمريض. هلا يعني مثلا lengthening بالعاده you need a compliant patient لانه هاي بدها يعني prolonged procedure, weekly follow up, hygiene for the device. You know that the percent of the penetract just for penetract infection it is almost 100%. It is then it is classified to the degree of the penetract. It is about 6 degree of penetract infection. فلذلك المريض إذا ما كان عنده compliance for such this device, for the hygiene, for lengthening, we face some patient بدال ما يطول عم بيقصر. اوكي وبدال ما يطول مثلا الجزء البار اللي بدنا اياه يعني بروح بطول جزء ثاني وبينتهي بكومبليكيشن. فبيختلف يعني بتعرف انت يعني معايير كثيره حتى عندكم. يعني انت مثلا بالسبورت في مرضى يعني ما بتقدرش تسوي عمليه وانت عارف انه هذا ما راح يعمل فيزيوثيرابي، ما راح يعمل يتابع، ما راح يلتزم بالتعليمات. اوكي فيعني مرات تشحط بريكات يعني خاصه انت يعني احنا هنا الموضوع يعني education of the patient يعني بصراحه بتغلب يعني بصراحه.
يا سيدي ثانك يو فيري ماتش. يسلموا دكتور ضياء، الله يسعدك. اشكرك
على سيدي.
واضحه.
الله يعطيك العافيه دكتور ضياء.
الله يعافيك على سيدي.
الله
يعطيك العافيه انت جدا المجهول ناصر.
حبيبي تسلم دكتور ضياء، الله يكفيك.
جزاه حسناتك.
سلام جميعا ان شاء الله.
السلام عليكم، كيف دكتور ضياء؟ في عندي سؤال بعد إذنك.
دكتور فيصل.
أولا الله يعطيك العافية على المحاضرة، صراحة رائعة. أنا عندي صراحة سؤالين. الأول إنه مثلا إحنا شفت بالتايب 1 السولتر هاريس في مرات بنستخدم كي وايرز.
ممكن ترفع صوتك بس فيصل لأنه بصراحة.
ألو؟
ارفع صوتك. أيوة سامعك.
بالتايب 1 سولتر هاريس مرات كنا بنستخدم الكي وايرز فور فيكسيشن. طب ما هم اصلا كي وايرز ممكن يعملوا انجري على الفايسز، يعني احنا عم نحطهم ثرو ذا فايسز، يعني هل في شيء معين يعني كم كي واير ممكن نستخدم؟ في فرق بالثيكنس اوف كي واير او بالاورينتيشن، يعني هل بيفرق معنا؟
هلا شوف، احنا بالعاده بنستخدم سموث كي وايرز. اوكي، هون بنستخدم كروسنج كي وايرز. من حق يعني انت بحاجه انه يكون الديامتر according to the size of the bone. هلا الفكره بالموضوع انك انت ما بدك تعمل further injury للفايسز. هلا ان اكسبيرمنت بالليترشر ذكروا انه up to 7% of physeal injury due to hardware the faces can accommodate this injury 7%. فلذلك احنا through the faces we advise just smooth K wires, not threaded, not screws. Okay, لأن it will end with further damage by heat, by direct damage of the faces. هلا بالنسبة للconfiguration of the fixation، هلا بنحكي إذا كانت small مثلا بالتايب 2، إذا كانت small fragment we can just do crossing. هاي موجود بالAO. هلا إذا كان large fragment بالميتافيزيال just parallel screw to the faces, that's enough.
شكرا دكتور ضياء. أسأل السؤال الثاني.
إيش السؤال الثاني؟
هل في يعني رول للاكسترنال فيكسيتر كمانجمنت عشان مثلا نقلل الفيزيال انجري او حتى يعني ما ناثر على البريوستيوم، يعني نترك الجوينت بحاله ونروح كاكسترنال فيكسيتر
طبعا
مانج؟
طبعا. هلا اذا كان عندك انت شورت سيجمنت، هلا اذا مثلا مريض عنده كومبايند فراكتشر، يعني زي الحاله اللي انا ورجيتك اياها اللي هي كومباوند فراكتشر سالتر هاريس تايب 4 اللي تعالج اول شيء بسكروز. اوكي، وما كان محقق اناتوميكال ريدكشن ولا الاستابيليتي، وبعدين عمل له ريفيجن وشفتوا قديش. انا يعني تعمدت احط الصوره انه قديش الميتال اللي انحط، يعني انت بريوستيال انجري راح صار غير الفيزيال، يعني بصراحه ما في داعي لكل هذا الميتال. هلا using of external fixator you can do it, okay, especially if there is short segment in metaphysis, if there is loss of segment of the bone, multiple intra-articular fractures, they compound like this fracture, you can use TSF for a fixation. طبعا تقدر.
شكرا دكتور ضياء، شكرا على المحاضرة الجميلة.
طيب شباب، في ضل حدا عنده اي سؤال لاي استفسار؟ دكتور ضياء.
يعطيك العافيه سيدي.
الله يعافيك. هلا
بس نسألك سؤال سيدي، بالنسبه اذا كان في عندنا فايزل انجري يعني فراكشر على البروث بليت associated with open fracture، يعني كان open fracture، بيفرق شيء بالمانجمنت؟ يعني بنعامل زي كأنه خلاص open fracture ولا زي البيدياتريك فايزل انجري، ولا كيف يعني كيف المانجمنت تاعت الابروتش بتكون؟
يعني انت بتحكي open fracture around associated with physeal injury، مظبوط ولا لا؟
يس exactly.
طيب هلا هذا بدك تعامله معامله الاوبن فراكتشر، الكونسيدريشن اوف اوبن فراكتشر، الكومبليكيشن اوف ذا اوبن فراكتشر especially in the faces. هلا sometimes يعني انت بتخاف انه يكون في عندك intra articular extension risk of septic joint. تمام. هلا regard the fixation زي اي open fracture، يعني نفس البرنسبلز. الفكره انك انت بتعطي للمريض دم انه انت have a higher complication after that. تمام، اللي هي regard the growth disturbance. تمام، فما راح تفرق يعني انت معك الموداليتيز، فممكن انك تستخدم يعني بهذاك الوقت تستخدم موداليتيز اللي زي ما حكى الدكتور فيصل انه اكسترنال فيكسيتر زي اي اوبن فراكشر.
اوكي سيدي يعطيك العافيه.
على سيدي هذا.
اي سؤال؟
العافية دكتور ضياء.
يعافيك.
إذا في مجال سؤال إذا سمحت، معك حمزة أبو عين.
هلا يا حمزة، كيفك؟
كيفك سيدي؟ الله يعطيك العافية ويسلم
يعافيك.
عليك. سيدي بس عندي سؤال بما يتعلق بموضوع الفيزياء البار. على سبيل المثال طفل عمره 10 سنين اجى بسولتر هاريس تايب 1، عملنا له فولو اب بعد شهر، لقينا عنده فيزياء البار ورايحه الديستريجس بفيروس. عمره تقريبا 10 سنين، يعني ضايله تقريبا 3 ل 4 سنين جروث ريميننج. ايش الموداليتيز اوف مانجمنت بهذه الحاله؟
هلا احنا حكينا انا يعني حكينا البرنسبلز اوف ذا مانجمنت اوف ذا فيزيال انجري، فيزيال بار. اذا كان عندك انت الفيزيال بار less than 50% تعمل فيزيال ريسكشن. اذا كان more than 50% من السيرفيس اريا اوف ذا فايسز بدك تعمل كومبليت ايش؟ ابيفيسيديسيس. تمام؟
تمام سيدي، يسلم عليك.
اوكي.
دكتور ضياء الله يعطيك العافيه.
الله يعافيك. هلا
علي المجالي معك سيدي، الله يعطيك الف عافيه.
هلا
وحضر
دكتور
رائع.
علي، كيفك؟
هلا يا سيدي. باشا الدكتور احمد مرزوق زمان بعث لنا فيديوهات عن عن البيدياتريك تروما، كان فيها كلاسيفيكيشن بيترسون.
نعم صحيح.
كان بيحكوا عن بيترسون انه هو يعني كارز مور بروجنوستيك فالويشن او مور
نعم صحيح.
بروجنوستيك عن تايب 1 وتايب 2. فبصفي لو بدنا كومبير تو سولتر هاريس راح يصفي سولتر هاريس تايب 1.
بعرفش انت لسه بعرفش اذا لسات انا عامل شيرنج. هلا اظن انه انا حاطه. واضحه؟
سيدي بالضبط. هلا اكوردنج هلا بيحكوا ببيترسون اللي هي عفوا سيدي ثواني، بيترسون تايب 1 وتايب 2 كارز ليس ريسك او ليس ريسك تو هاف جروث ارست ذان تايب 3 بيترسون اللي هي ايكوال تايب 1 شولتر هاريس. هلا
شوف دكتور علي، هلا بيترسون انا معك انه هاز جود بروجنوستيك، بس هلا ما بيستخدموه لانه الفيموس اللي هو سالتر هاريس. هلا كل ما زاد الجريد تاع البيترسون زادت ايش؟ المور يعني باد بروجنوسيس. تمام؟ فلذلك بس اما هلا بطل حدا يعني يستخدم بيترسون بصراحه، لانه كل العالم عم يشتغل على موضوع السالتر هاريس. تمام؟ هلا يعني في تقارب كثير ما بين سالتر هاريس زي ما انت تفضلت. يعني انت بتحكي مثلا عن some types of the Peterson، هي نفس السالتر هاريس. كان في عندي انا صور، بس انا حبيت اعجق الشباب فيها لانه مور ادفانس يعني بالموضوع. وبالاخر انت بهمك شيء انك يعني خلص تعتمده، والجميع العالمي يعني هذا وورد وايد كله معتمد السالتر هاريس وماشي عليه يعني. بس البيترسون اجى قبل موضوع السالتر هاريس، يعني انت بلش من الثلاثينات. فهمت علي كيف؟ لو بدك تحكي عن الهيستوري تاعه.
يعني سيدي احنا بالنسبه للجروث ارست ريسك بنمشي على ترتيب سولتر هاريس من 1 ل 5.
اوكي صح؟ بايش قصدك، على بيترسون ولا سولتر هاريس؟
لا على سولتر هاريس. يعني سولتر هاريس تايب 2 كاريز مور ريسك تو ديفلوب جروث ارست ذان سولتر هاريس تايب 1.
لا هلا حكينا احنا تايب 5 وتايب 4، هذول هاز هايست ريسك فور فيزيال انجري. حكينا على الفيزيال
بس اكيد، بس كومبيرينج تايب 1 مع تايب 2.
تايب 1 مع تايب 2، هلا قديش انت تايب 1 اذا كان عندك كومبليت ديسبيسمنت ولا لا؟ هلا بتختلف. هلا دكتور علي بتختلف. انت عندك الميكانيزم اوف ذا انجري. حكيت انا اذا انتبهت في المحاضره قلت انه في عندك انت تويستنج انجري وفي عندك ايش؟ لونجيتودينال انجري. اذا صار عندك انت تويستنج انجري يعني عملت زي جريندنج، زي كانك بتطحن بالفايسس، هذا راح يعمل مور دامج. راح يدمر البلاد سبلاي الموجود هناك. فهمت علي كيف؟ فاند with a more bad prognosis.
تمام، اشكرك سيدي، شكرا جزيلا.
وضحت الصوره؟ بس خلص
واضحه جدا.
يعني انا حبيت ان اقول لكم في اذر كلاسيفيكيشن حتى على الفيزيال بار، في اكثر من كلاسيفيكيشن. هلا اخر شيء هم رسخوا على سنترال بيرفرال اند لونجيتودينال لين. تمام، هذول اسمبل. هلا في عندك اي بي سي او بي سي اي، يعني كل واحد اوجدن عمل لك كلاسيفيكيشن. هذا موضوع يعني شيء ادفانس، يعني بالحياه العمليه ما بيهمني. خلص انا بدي كلاسيفيكيشن وورد وايد الجميع متفق عليه واحنا بنمشي عليه، يعني لغه تفاهم ما بين جميع الجراحين وخلص. واظن انه هو بغطي جميع التايبس اوف ذا فيزيال انجري. يعني مع الموديفيكيشن قلت لك ضافوا موديفيكيشن بال 81 اللي هم 6 و7 و8 و9. تمام، فاظن هذا يعني هو شامل للفيزيال انجري.
تمام سيدي، مشكور مشكور مشكور.
لا بالخدمه.
يعطيك العافيه سيدي. رعد شطناوي معك.
هلا شطناوي.
سيدي بدي اسال لو سمحت، اول شيء شكرا على المحاضره. هل في consideration of contralateral epiphysiodesis بالupper limb injuries؟
بالعاده احنا حكينا الجروث ديستربنس بالابر ليم. شفت انت الدراسه اللي انا دقيقه اورجيك اياها. You can imagine that it is proximal humerus very rare، اللي هي 80% من الجروث بيجي بالهيومرس من البروكسيمال هيومرس، والديستال radius just 4 to 5% if there is displaced fracture. تمام، فلذلك الكومبليكيشن فور جروث ارست بهذاك يعني بالابر ليم فيري رير بصراحه. يعني احنا بالعاده يعني بنشتغل على اللور ليم، يعني حتى لو كان هذاك الفرد ما راح ياثر فانكشنالي على البيشنت.
شكرا سيدي، شكرا.
تمام، اوكي.
طيب أي سؤال شباب؟ طيب إذا ما ضل أسئلة، نشكر دكتور ضياء على محاضرته القيمة. شكرا دكتور ضياء على جهودك.
العفو ناصر، والله
يعطيك العافية يا سيدي. وإن شاء الله الآن نتوجه لرابط جديد راح أبعث لكم إياه مشان نبدأ بموك إكزام اللي حكينا عنه. والله يعطيكم العافية.
الله يعطيك العافيه.
الله يعافيك يا سيدي.
الله يعطيكم العافيه جميعا، وان شاء الله نكون استفدتوا يعني من المحاضره.
أكيد سيدي، محاضرة ممتازة وقيمة. شكرا لك.
الله يعطيك العافيه. هلا.